Good morning, everyone. Thanks for taking the time to come to this talk, and thank you to the Cancer Society for the opportunity to speak to you this morning. My name is Fionán Donohoe. I am a specialist registrar in obstetrics and gynecology, and the last 2 years of my life were spent, and I suppose it continues to be spent, working in this area of cancer-induced or cancer-associated menopause and menopause symptoms. And I was asked to give this workshop today by the Cancer Society because I was fortunate enough to, over the last 2 years, to run the Menopause After Cancer study, which is supported by the Irish Cancer Society and Women's Health Initiative. And I'm part of the UCD arm of that and the work we're doing around trying to improve the experience of cancer-associated menopause. So I have certainly spent a lot of time learning about this, and I hope to be able to impart some of that information to you this morning, and there'll be time for some questions and answers at the end. I hope that my Y chromosome, my gender, doesn't act as a barrier to the information that I'm going to share with you all this morning. So in terms of an overview of what the talk will contain, we'll start with a brief overview of what is menopause. We'll explore the link between cancer and menopause symptoms. We'll learn what the symptoms of menopause are, what treatments are available, and then at the end, we'll have some questions and answers. So starting first, if you're being technical about it, that the word menopause, what it means is the final menstrual period. So the last period that a woman has in her life is the technical definition of what menopause means. But in the modern world, the word has come to represent the syndrome of symptoms and signs associated with menopause. And we have this word perimenopause now, which is defines that period of time from the first onset of menopause type symptoms until the cessation of menstruation or until periods stop. And what can often be confusing when you're dealing with menopause symptoms in the context of a cancer diagnosis is that the term perimenopause often doesn't fit neatly in what is happening to you because of the treatment that you had. So perimenopause really is for people who are undergoing what we call physiological menopause, menopause that's happening in the context of the normal run of the reproductive cycle, rather than something that's induced or exacerbated by cancer treatment. And the term postmenopause refers to when there has been no period for more than 12 months. And any bleeding after this time is considered abnormal and should be investigated. So this is an image trying to demonstrate how the menstrual cycle works. So in someone who is of reproductive age, and the menstrual cycle is usually 28 days, and there are a number of hormones involved in regulating that cycle. So the hypothalamus, as you can see at the top of this picture on the right side of the screen, is an area in the brain which secretes this hormone GnRH, which stimulates the pituitary, which is another gland at the base of your brain, which stimulates lots and lots of different hormones. But in terms of reproductive cycle, they secrete LH and FSH, which stimulate your ovaries to create estrogen and the other hormones that your ovaries create. And this works in kind of a feedback mechanism. So the hypothalamus tells the pituitary to create the hormone. The pituitary tells the ovary to create the estrogen. When the estrogen is created, it feeds back to the pituitary that they need to make less of the hormones that they secrete. And what this results in, as you can see on the left side of the screen, is an increase in estrogen in the first half of the menstrual cycle, then an increase in progesterone in the second half. And all of this is designed to create a thickened lining of the womb for implantation of a pregnancy. And then if no implantation occurs, progesterone and estrogen continue to fall, the period happens and the cycle resets. So what happens when we're born, when a baby girl is born, she's born with all the eggs that she'll need for her reproductive life. And over the next 40 to 50 years, those are slowly used up. And once they have been used up, you start to develop menopause symptoms as the ovaries lose their function. So you can see after menopause, estrogen and progesterone gradually fall to a very low level. It's not a no level, it's a very low level. So where does cancer come into all of this then? And there are a number of ways, and we'll go through each of these in turn. And And the first thing I'll speak about is surgical menopause. So, as many of you will know or may have experienced, the ovaries are often removed at surgery for different types of cancer. So, what this means is that the ovaries are removed, and therefore estrogen can no longer be produced in any meaningful quantity. And this is most really relevant in the gynecological cancers, particularly ovarian cancer and uterine cancer, but it's becoming more relevant as we see in advanced colorectal cancer. There may be spread of the tumor to the ovaries, and it may require removal of the womb and the ovaries at surgery for an advanced or locally advanced colorectal cancer. But it's also relevant in the setting of risk reduction in women with BRCA, Lynch, or other genetic alterations which increase their predisposition to cancer. And then obviously ovarian suppression. Sometimes if you have breast cancer and you need to undergo ovarian suppression to reduce your risk of recurrence, having your ovaries removed surgically is one way of having that done. So surgical menopause can be very accurately timed, and it is permanent and irreversible. So you don't have a period of time where your hormones are slowly decreasing. They are kind of removed quite suddenly when the ovaries are removed from the body. If we're turning then to pelvic radiotherapy, so as we know, radiotherapy very effectively kills cancer cells. But if it's given to the pelvis, it's very difficult to protect the ovaries from the spread of the radiation, even with the modern techniques that are used nowadays to target tumors quite closely. And so this ovaries are very sensitive to the radiotherapy, and any exposure of even a small amount of radiotherapy to the ovaries causes the cells in the ovaries that create estrogen to lose their function and push the patient into menopause. This is obviously relevant mostly in the gynecological cancers, in cervical cancer, as we often use chemo and radiotherapy to treat cervical cancer. But also we're seeing it more in rectal cancer, which is used before surgery to try and shrink the tumor in women with rectal cancer. And we know this is on the rise in women under the age of 50, so it is becoming more relevant as time goes on. And again, menopause induced by radiotherapy is permanent and irreversible. And obviously there are other shorter and longer term effects also associated with pelvic radiotherapy, as many of you will know. Chemotherapy then is a little bit more nuanced and can be a little bit more difficult to kind of counsel about in advance of the administration of chemotherapy. So as you all know, chemotherapy is designed to kill cancer cells. And similarly, the ovaries are very sensitive to certain types of chemotherapy. And if the chemotherapy can then cause the cells in the ovaries to be affected and not be able to produce estrogen, and that can lead to menopausal symptoms. So, however, with chemotherapy, in some cases, this would be reversible, and ovarian function may return once the chemotherapy is completed. And in other cases, it will be permanent. And we know that it's more likely to become permanent the closer you are to the natural age of menopause when chemotherapy is given, which is the natural age of menopause is around 51 in this part of the world, but it's not really predictable before or afterwards whether or not menstrual cycles and ovarian function will return. And sometimes it can be a case of it will return, but not in the same way, in that there may be still some estrogen produced. You may still have a menstrual cycle, but you may also be dealing with menopause symptoms. Or in some cases, the ovarian function will return, but only for a short time, and you might end up going into menopause earlier than the natural age of menopause, even though it may be several years since the chemotherapy was given. So the administration of chemotherapy does represent a sort of a hit to the ovaries, if you like, which in some cases they can bounce back from, and other cases they can't. Endocrine therapy then is the medications that are given to women who've had breast cancer after they've completed treatment to reduce the risk of recurrence. And I'm talking about medications like tamoxifen or aromatase inhibitors such as letrozole, exemestane, and so many different brands of that particular family of drugs. And also Zoladex injections are very commonly given for the treatment of hormone receptor positive breast cancer to reduce the risk of recurrence. And these are often given over a longer term, sometimes 5, sometimes even 10 years. And Zoladex injections, Zoladex is a synthetic form of the GnRH hormone, which is secreted by the hypothalamus in the brain. And increases the secretion of that to trick the body into thinking it has gone through menopause. So periods stop, ovaries reduce their function, and then tamoxifen and aromatase inhibitors work by lowering the estrogen level even lower. And this can induce vasomotor symptoms. Even if it's 10 or more years since you went through menopause, you might find that you're getting hot flushes, sweats, and so on back again. And that's not that you've been put back into a menopause type picture. It's that these medications lower the estrogen so low that it's bringing back those symptoms that you would have remembered from when you went through menopause previously. And if you have ongoing menopause symptoms, they're likely to worsen once you start tamoxifen and aromatase inhibitors. So there are, in terms of what are menopause symptoms, there's a long potential list of menopause symptoms. And if you Google what are the symptoms of menopause, the list is extensive. And almost any symptom that it's possible to experience has been attributed to menopause over the years. There are, however, it's difficult to say what is 100% definitely due to menopause. And what I mean by that is, what are the symptoms that are definitely due to low estrogen and low other hormones that the ovaries secrete? And we know there's a significant overlap between what sometimes are considered menopause symptoms and what are often symptoms of a normal aging process. And in the oncology setting, we know that there can be significant overlap between the side effects of cancer treatment and menopause symptoms. And in particular, there you see fatigue, and that's obviously a huge side effect of cancer treatment, regardless of your gender, but obviously can be exacerbated and is often tried to be attributed to menopause, when in reality, it's probably an interplay of both. Obviously, loss of fertility and coping with that can also make coping with menopause symptoms more challenging, depending on the age that you're experiencing them. So in terms of what do we definitely know are due to menopause, what symptoms that we definitely know are related to low estrogen and low other hormones that the ovary secretes, is that irregular or no periods is definitely due to that. Vasomotor symptoms, what we call hot flushes if you're in Europe, or hot flashes if you're in North America, night sweats, and general heat intolerance, which can be associated with skin flushing and a sensation of heat. And there's a huge variety of symptoms included under this umbrella term of vasomotor symptoms. So some people will just feel very warm. They may not necessarily have skin reddening. Some people will have drenching sweats at nighttime and during the day. Other people will just feel really, really warm and won't sweat. And it can be very uncomfortable for many people. But there isn't a correlation between the experience of these symptoms and any particular duration or any particular cause of menopause. It's very variable between women. Genital urinary symptoms, and by that I mean vaginal dryness, which can cause pain with sex, discomfort with exercise or activities of daily living, recurrent urinary tract infections and urinary problems. That is definitely associated to the lack of estrogen in menopause, and we'll come on to discuss treatment of that as we go through the workshop this morning. Mood symptoms are also correlated with low estrogen, and so is sleep disturbance. So these symptoms are definitely, from the research that's been done so far, we know are definitely due to the hormonal deficiency associated with menopause. So I think, and this is from the British Menopause Society, so if we look, this is sort of the cogs of the wheel, and they kind of are interplays of each other. So on the bottom side here, we have hot flushes, night sweats, and hormone changes. And that's the cog which induces sleep problems. And if we're not sleeping, we're more stressed, we're more anxious, we have lower mood. And these kind of things all play in to feed off each other and create a situation of menopause symptoms, which can be difficult to deal with for many people. So other symptoms which are commonly reported as due to menopause but are poorly understood is brain fog and cognitive issues. And there's obviously significant overlap between the treatments of chemotherapy often induces brain fog and cognitive issues. And there's obviously an overlap between that and menopause. Aches and pains, again, people will have a lot of bone pain. Is it down to menopause? Is it down to aromatase inhibitors on their own? And it's, again, probably best seen as an overlap rather than having one singular cause for these symptoms. Dry eyes, skin, and hair are all associated with aging. And it's unclear based on the research done so far, whether or not this is because of a lack of estrogen. And people often report weight gain and change in the kind of body shape and change in fat distribution. And we know that there is more fat deposition as we age. We don't know if that's down to hormonal changes or down to aging. And we know that we lose muscle as we age. And if we lose muscle and our fat is distributing in a different way, our body shape changes. But it's unclear whether or not that is actually due to hormone deficiency or as a consequence of getting older. So how is menopause diagnosed then? And often it can be quite difficult to diagnose menopause because symptoms can be quite subtle and easily missed even by the people experiencing them. And what I will say though is if you have gone into menopause because of surgical removal of the ovaries or pelvic radiotherapy, no tests are needed as menopause is inevitable, unfortunately, after these treatments. Blood tests can be helpful if you're under the age of 45, but levels do fluctuate, and the hormone that we check for can be normal at one check and abnormal on the other, which can make the diagnosis challenging. So it's best really to go by your symptoms and to see what you're experiencing and talk to your doctor and to, ask the question, could it be menopause, and exploring things that way. But if you're over the age of 45 and your symptoms are suggestive of menopause, and by that I mean flushes, sweats, vaginal dryness, mood changes and sleep disturbance, those are the classic reliably attributed to menopause symptoms, then it's reasonable to assume that it's menopause causing them and initiate treatment based on the predominant symptoms. So what I will say in terms of treatment is that it's important to say that every single woman's experience of menopause is unique to her. So many women have no symptoms at all and move through the menopause without any particular cause for concern. And even women who have surgical menopause or menopause induced by radiation will often have no symptoms at all. Most people have mild symptoms and some have severe or moderate symptoms. But everyone's experience is their own, and there's no point in comparing someone else's experience to yours. The treatment of menopause is based on an individual woman's experience of the symptoms, her desire for treatment, and the degree to which those treatments interfere with her daily activities or interfere with her quality of life. And treatment is instituted based on that rather than kind of a blanket rule for everybody. So while I'm here this morning trying to have a one-size-fits-all conversation about menopause, it can be difficult to do that because everyone's experience is so unique and so individual to them. So in terms of my key messages today, menopausal symptoms happening at the normal age more than 45 that are mild and don't impact on your quality of life do not require treatment. So it's important for everyone listening that if your symptoms aren't affecting your quality of life, you don't need to have treatment. Treatment for menopause is not mandatory. Treatments can be hormonal, but also non-hormonal medications or prescribable non-HRT or non-pharmacological. And I think it's really important to mention that a solid foundation menopause really starts with approaching exercise and eating well. And I know there are other talks over the course of today on both of these areas. And so I'm not going to dwell too long on them because I'm not an exercise expert or a dietitian or a nutritionist. But in terms of, just to mention briefly with exercise, there is evidence to show that it helps with the mood and anxiety symptoms of menopause and mood and anxiety symptoms in general. It helps with sleep and insomnia, and it helps with fatigue. So those are three big areas that we see associated with menopause and also associated with cancer treatment. And it may help with aches and pains, weight gain, and the brain fog and cognitive issues that I mentioned earlier. The one thing exercise probably doesn't help with is hot flushes and sweats and those vasomotor symptoms that we discussed earlier. So in terms of self-management, so I think it's a good idea to look at what you can do to try and help as much as possible is to avoid triggers. So we know alcohol, spicy food, and caffeine can all trigger the vasomotor symptoms associated with menopause. Basic things like dressing in breathable fabrics like cotton, to wear layers so that if you do feel warm, you can take a layer off, keep a fan and a cool drink nearby, which are very basic, but I think worth mentioning in terms of trying to manage those vasomotor symptoms that are the most common symptom of menopause. And eating well and taking regular exercise also complements all of this. So in terms of the non-pharmacological, so trying to treat your menopause symptoms without medication, and CBT, or cognitive behavioral therapy for menopausal symptoms, it has really good research to support its use. Now, mostly it's looking at hot flushes and how those symptoms affect our thoughts, feelings, and behaviors. But the data around it is really, really good. That people's experience of menopausal symptoms of those hot flushes is much improved after undergoing a course like this. And the evidence says it's beneficial in a one-to-one, but also through group courses. And there are therapists trained to deliver CBT for menopause symptoms in Ireland. So if non-pharmacological approaches are something that's interested to you, then it's definitely something to consider. In terms of supplements, there's the data around supplements for vasomotor symptoms is really poor, and I don't generally recommend any supplements to patients because they don't seem to help. Now, are there harms to them? Probably in very limited cases, and the Memorial Sloan Kettering Cancer Centre have a really good online resource about herbs where you can check to see, does it have any interactions with the medications that you're taking and what the different thoughts and evidence is around them. But in terms of her vasomotor symptoms, I don't recommend them to patients because the research that we have at the moment shows that they don't help. There are small studies that are sort of poorly designed and subject to bias, which show some small benefit. But when you compare it with placebo, compare these supplements with placebo, they don't seem to help with the vasomotor symptoms that aren't the most common symptom of menopause. So turning then to hormone replacement therapy, and as I'm sure everybody knows, we're having a huge conversation nationally and I suppose internationally as well about menopause and about HRT in Ireland. And I think sometimes the people who are experiencing menopause in the context of a cancer diagnosis are left out of that conversation to an extent, because there has always kind of traditionally been a fear about HRT and cancer and so on. So what we do know about HRT is that it is the most effective treatment, but it does not eliminate all symptoms. For most people, it doesn't get rid of all of their symptoms. And if we think about it, the ovary is a very complex endocrine organ that has so many functions in terms of regulating our menstrual cycle, but also in pregnancy, strengthening our bones, protecting our hearts. And estrogen has action in almost every tissue in the body. So really, it is naive to think that by administering one or maybe two of these hormones through hormone replacement therapy, that we can really eliminate all the symptoms that women experience with menopause. The main indication for vasomotor symptoms is main indication for hormone replacement therapy is vasomotor symptoms. But there are other benefits seen associated with sleep, mood, and obviously protecting our bones from osteoporosis and osteopenia. So HRT can be given systemically, and by that I mean to your whole system. So via a patch, it can be given orally through tablets or through gels that you put on your skin and are absorbed into your system. So estrogen-only HRT is given estrogen is given really to manage those vasomotor symptoms. And then if you have a uterus, progesterone is given to try and prevent the estrogen from causing any abnormalities in the uterus. If you don't have a uterus, if you had a hysterectomy for whatever reason, and you're taking hormone replacement therapy, you only need to take estrogen. HRT does not seem to help with brain fog or aches and pains based on the research that's been done, the kind of reliable, reputable research that's been done so far. It does not seem to help with those symptoms. And as I mentioned previously, that's probably because they're partially due to menopause and partially due to other things that are going on. So if your menopause starts early, so that's less than 45, or premature, which is less than the age of 40, and you have no contraindication to HRT, we'd recommend continuing it until at least the natural age of menopause, which is 51. And then we would recommend to weigh up the pros and cons on an individualized basis to determine if or not you want to continue HRT beyond that time. And as I think it's really important that HRT does not eliminate all symptoms, and the maximum effective treatment is seen at 3 months of use. So it usually isn't an overnight thing where you feel better instantly. Now, some people do have that experience, but for most women, you have to sort of assess treatment at 3 months before making any changes. So looking at HRT after a cancer diagnosis. So at the top of the screen here, we have the cancer types where HRT is usually safe to give if it's needed. So in colorectal cancer, vulval or vaginal cancer, cervical cancer, leukemia and lymphoma, there doesn't seem to be, from an oncology perspective, it doesn't seem that HRT increases the risk of the cancer coming back. It doesn't seem that HRT is dangerous to use in those situations strictly when you're considering the cancer. Now, individual patients may have other health issues and risk factors which make treatment more challenging, but if you're considering from an oncology perspective, these tumors at the top of the page, these cancer types at the top of the page, don't seem to have any concerns about the use of HRT for them from a risk of recurrence perspective. On the left side of the screen, then we have certain circumstances where HRT can be used sometimes. So in endometrial cancer, that's very early stage. It appears safe to use hormone replacement therapy in well-selected cases. In some types of ovarian cancer, in early stage melanoma, and in lung cancer, there's not really consensus about whether or not estrogen is associated with lung cancer, so it can be used in certain circumstances. And then on the right side of the page, we have the types of cancer where HRT should be avoided if at all possible. And the main one there is breast cancer and some subtypes of ovarian cancer. So I know breast cancer is something that comes up a lot, and I know that obviously breast cancer treatment induces menopause in a lot of cases and induces a lot of menopause symptoms, even in postmenopausal women. So these are the three largest, most reputable research projects that have been done investigating whether or not hormone replacement therapy is safe if you've had treatment for hormone receptor breast cancer. So the first two, the HABITS and the Stockholm trial, were both conducted in Sweden. And they looked at a comparison of all people who had early stage hormone receptor positive breast cancer and randomized them, and menopause symptoms, randomized them to receive HRT or a placebo, and followed them up over a number of over a period of time to see what the risk of the breast cancer coming back was. So the HABITS trial was the first one, and they had to, once they did a kind of they were sort of halfway through, they did an interim analysis to see how things were looking, and it looked like there was a significantly higher risk of recurrence in the group of people who were taking hormone replacement therapy. So due to safety concerns, the trial was stopped. The Stockholm trial was looking at a similar population of patients, and once the HABITS trial was stopped, it was stopped as well. So when they analyzed, on the right side of the screen where it says results, you see that HR 3.5 and HR 1.8. That means the hazard ratio, so it was 3.5 times more likely for the people taking hormone replacement therapy to have recurrence than those who were taking placebo. And in the Stockholm trial, it was 1.8 times more likely for the people taking hormone replacement therapy to have recurrence than those taking placebo. The last trial, the Liberate trial, is a large study, I think, from North America, which analyzed tibolone, which is a type of medication which can be used to give menopause symptoms, it's a steroid type medication which has estrogen type properties. And again, they showed 1.4 times higher risk of recurrence in people taking tibolone for menopause symptoms after breast cancer. So there are lots of other studies which are have, I suppose, a higher risk of bias because they don't randomize or use placebo to try and find an accurate result, which show the opposite of this. But these are the most reliable trials, and this is the reason why people are often very reluctant, or why we recommend that people who have had treatment for breast cancer avoid hormone replacement therapy if at all possible. So if you've never had breast cancer, and if you had another type of cancer and you're taking HRT, I think often people can be concerned about the risk of developing breast cancer from taking HRT if you've never had it before. So it's worth just looking at those risks, I think, in pictorial form. So if we take 1,000 women aged between 50 and 59 in the UK general population, 23 of them will develop breast cancer over the next 5 years. An additional 4 cases will be seen in women taking hormone replacement therapy combined. So that means estrogen and progesterone. But 4 fewer women will be diagnosed if they're taking estrogen only hormone replacement therapy. 5 cases in women who drink 2 or more units of alcohol per day. So the risk of drinking 2 or more units of alcohol per day is greater than the risk of taking HRT in terms of developing cancer over the next 5 years. 3 additional cases in women who are current smokers, 24 cases in women who are overweight or obese, and 7 fewer in women who take at least 2.5 hours of moderate exercise per week. So the risk, if you've never had breast cancer, the risk of developing breast cancer because of HRT is slightly increased if you're taking combined HRT, but much lower risk than being overweight or obese or even drinking a very moderate amount of alcohol. Turning then to local symptoms, these can have a significant impact on quality of life. So vaginal dryness can cause sexual problems, but also discomfort with day-to-day living, recurrent urinary tract infections. And there are non-hormonal options like lubricants, which can be useful for intercourse, and vaginal moisturizers, which can be used kind of to manage general dryness. And topical anesthetic ointments and gels can also be used if sex is particularly painful. But vaginal estrogen is by far the best treatment and is really effective and safe for almost everyone to take. Even people with hormone sensitive cancers can usually take vaginal estrogen for their local symptoms. So kind of feeling itchy and scratchy, and particularly with exercise, is often a sign of vaginal dryness, and using vaginal estrogen is really effective and safe. It does increase the amount of estrogen absorbed systemically for a very short period of time once you first start taking it, but that then comes back down to the postmenopausal range, which is essentially nothing. So it is the most effective and safe treatment and works really well and can really be a game changer for a lot of women. And if you're on HRT, so tablets or patches or gels systemically, then oftentimes you might also need vaginal estrogen in addition to that. If you have local symptoms, then this leaflet is available on the thisisgo.ie website, which is another Irish Cancer Society sponsored initiative. And I think there's a stand at the conference today for our team from thisisgo.ie. But this leaflet is super detailed and has everything you could possibly need to know about improving your vulvovaginal health after a cancer treatment and cancer diagnosis. So I'd really recommend checking this out if you're dealing with those symptoms. In terms of looking at non-hormonal options for managing hot flushes, there are several medications which are normally used for other reasons. So SSRIs and SNRIs are used to treat depression and anxiety usually, but they kind of found as almost as a mistake or a by the way that they also were helpful for managing hot flushes and sweats and those kind of vasomotor symptoms of menopause. So citalopram and venlafaxine, which are also known as Cipramil or Effexor, do have lots of good evidence to say that they reduce the amount of flushes and the intensity and severity of them. Gabapentin, which is often used to manage nerve type pain, can also be helpful. And oxybutynin, which is normally used for overactive bladder type symptoms, also has evidence to show that it helps with hot flushes and sweats. Now, it probably won't help. Gabapentin does help a bit with your sleep, but they don't help with the other menopause symptoms, generally speaking. SSRIs and SNRIs may help with your mood, but they're not as effective as HRT for hot flushes or sweats. But they are an option if you want to consider them in addition to or instead of the non-pharmacological techniques that I mentioned at the start. They are an option. A lot of people are reluctant to take more medication or don't want to take medication for something that's a side effect of another medication they're taking, and absolutely we can understand that. But these medications do work if given time and if started and the doses increased appropriately. Low libido and loss of interest in sex can be a huge challenge with menopause in general, and particularly in the context of cancer treatment. I know there's a talk on this in the conference today as well, but I just want to draw everyone's attention to this this leaflet, which is created by the European Network of Gynecological Cancer Advocacy Groups. It's really excellent and goes through a lot of different techniques to try and help overcome low sexual desire after cancer treatment. You can just Google it and it's available freely for everybody. Testosterone is a medication which we're hearing a lot of. Unfortunately, we have no licensed products for women. So anyone who's using testosterone to manage low libido is using a product that's designed for men, but using much less of it. And studies do show a modest improvement in libido in postmenopausal women who are already taking estrogen and progesterone. But we have very little in the way of long-term safety data. And we've no randomized data about, no kind of reliable information about whether or not it helps with musculoskeletal concerns like muscle loss and so on, or cardiovascular or other reported benefits that you see mentioned about testosterone. And research is needed after hormone sensitive cancers, because really there isn't any out there. When you go to the British Menopause Society, as you can see there, a history of hormone sensitive breast cancer is a reason to avoid testosterone if at all possible. But obviously off-label exceptions to everything is possible in fully informed women with intractable symptoms not responding to alternatives. So other issues with menopause that often come up are bone health, and we know that hormone replacement therapy can be helpful, but if you can't have HRT, calcium and vitamin D supplementation are really important. Avoiding smoking or medications which are known to cause bone thinning, and take regular weight-bearing exercises or things you can do yourself to try and keep your bones healthy. There's an excellent leaflet done by the National Cancer Control Program about bone health after cancer treatment, which is really worth checking out. Cardiovascular health, again, is something that which really comes up. And we know HRT may help from the prevention of heart disease, but we don't really have the kind of reliable information as yet as to whether or not that is the case. And HRT is not licensed for the prevention of heart disease. We don't start people on HRT because they're at a higher risk of heart disease after they go through menopause. We only start HRT for people who have symptoms that need treatment. And so in terms of your cardiovascular health, it's important to maintain a healthy diet, avoid smoking, and obviously talk to your GP if you're concerned, because GPs are really the champions of health promotion. Looking then to the future, as I come to finish up, it's a really exciting initiative between our group in UCD, which are obviously supported by the Irish Cancer Society, the National Cancer Control Programme, and ARC Cancer Support Service in Dublin are developing, in the process of developing, a survivorship program for cancer-associated menopause and menopause symptoms. And it's hoped that we'll be able to roll this out at first in Dublin. At the moment, we're kind of designing the program, and some of you may have fed into that through a kind of a public and patient involvement group that was run. And we're hoping then to be able to roll that out at different cancer support centres nationally, to try and provide a group where we're giving education, but also providing a source of peer support for people, because sometimes it can be a bit lonely dealing with cancer-associated menopause symptoms. Looking then at new treatments that are coming out, there's a family of medications called neurokinin receptor antagonists, which the trials are beginning in people with cancer-induced menopausal symptoms. And we're hoping that these may be available to patients in Ireland, but we're just waiting to see. But initial results from people dealing with physiological menopause symptoms seem very promising, with high response rates of more than 70% and a very rapid onset of action within a few days, which is much quicker than estrogen. So it might be that these will become the first line treatment for hot flushes, menopausal hot flushes and so on. So where can you go to get help? There's a host of resources online. I've mentioned this is go.ie, again, sponsored and supported by the Irish Cancer Society, and a stand is at the conference today if you want to go and check that out. It's tailored for people with gynecological cancers, but there is lots of information there that's relevant to you, to anyone who's had treatment for any type of cancer. So it's worth checking out, even if you haven't been through a gynecological cancer yourself. The Women's Health Concern website is a real resource of patient information. The Menopause Matters website is a really excellent North American website called mymenoplan.org, which is really comprehensive and goes through all the different symptoms and treatments, and is all very evidence-based. Your GP is a really good first port of call, and the vast majority of menopause experts in Ireland are actually GPs, so it's worth starting there if you're struggling. There are complex menopause services starting to come online now. There's one currently open in the National Maternity Hospital. Referrals are there for people from Dublin, Wicklow and Kildare, and there's plans for more clinics to open up nationally. Talk to your oncology team, arm yourself with the knowledge so that you can self-manage certain symptoms, and talk to your friends, family and colleagues to normalize menopause symptoms and reduce stigma. Every single woman on earth will go through menopause if she lives long enough. So we should really be trying to take the conversation around menopause and the experience of menopause out from the shadows, because it is, for many people, something that they go through at the normal time, that yes, they need support for, yes, they may need treatment for, but it is something that happens to everybody. So why are we not talking about it? Online and in-person support groups can also be helpful. And of course, the Cancer Society and our local cancer support centres often provide huge support and resources to people all over the country. In terms of for healthcare professionals, we did the Irish Association of Nurses in Oncology. We did this series of podcasts about menopause and cancer, which is really worth checking out. It's tailored towards healthcare professionals. So if you wanted to suggest that to the people, to your healthcare teams, you absolutely can. And this is a paper that myself and our team authored about using hormone replacement therapy after cancer diagnosis in Ireland. Goes through all the common cancer types in Ireland and the different rationales and evidence to support the use, or to go through any tissue cancer types where it's kind of advised to be cautious with HRT. So thank you for your time, and I will gladly take any questions.
Hello, Fionán. Sorry, this is Aileen.
Hi, how are you?
Not too bad. Thank you for that wonderful and very comprehensive overview of cancer and the menopause. So if anybody would like to ask any questions out there, please type in the chat box.
I've covered it all.
You have, yeah, and it was very comprehensive from the I loved the bit on the self-management bit, and I think from my years of working with women, it's to encourage them to talk about the symptoms maybe that they're having, and there is loads of help available, whether it's you could start the nurses in the daffodil centres, the Irish Cancer Society support line, your clinical nurse specialists, advanced nurse practitioners, GP, as you said. But I think when women start to talk about it, when they realise that they're not the only one,
absolutely,
and around that, from the self-management point of view, I suppose the cancer support centres run maybe the self-management courses like the Cancer Thrive and Survive, and then they hear
absolutely,
other women talk about their experience.
Yeah.
But they can engage with the energy therapies as well, which I've always found was very helpful. Maybe the Tai Chi and the Qigong, just the breathing in itself. Yeah. So that can be the beginning point.
Absolutely, and I know acupuncture is available in a lot of the cancer support centres, and there is actually evidence to support its use for managing menopause symptoms. And someone just asked that question. I preempted it. But yeah, no, there is some data say acupuncture helps. It certainly doesn't harm, and it can be beneficial. And like you were saying, I think women speaking to each other and taking the conversation of menopause out from the shadows and out from the darkness is really where the growth is. Because if we're in a position where someone having a hot flush isn't abnormal, it's just a part of life, then it becomes less frightening, less scary, less uncomfortable if we're in that place, So I think that talking to each other and continuing that conversation is really important.
And even with that, there's a regular walking group, which was wonderful for them in many respects. And it is that non-medical management and giving them the power over themselves so that they can intervene. So I'm just looking at a couple of comments. You talked about the acupuncture. What will happen to symptoms once you stop tamoxifen?
It's really hard to know. For some people, their symptoms will get much less. They may have still some symptoms. Some women have no symptoms at all once the tamoxifen is stopped. And other people will find no difference. And there's no way of predicting what will happen. It just depends. You just have to, when it's time to stop it and see. And the duration of symptoms, we really don't have any information at all in the literature about how long cancer-induced menopause symptoms last. There is some information about physiological menopausal symptoms and how long they last. It's very variable. We don't have any data about cancer-induced menopause symptoms and the duration of those for most women. So that's something that kind of has to be a research priority, I think, going forward.
I can remember anecdotally in some groups of women where those who were experiencing the menopause answered that sometimes double digits.
Yeah, no, absolutely. Yeah, some people have a really, really tough time with it.
So Pascaline, what can you take instead of Invagis, and Vagifem when not allowed? I've had breast cancer ER positive, but I'm on a clinical trial that doesn't allow Vagifem or Invagis.
So I would really recommend going on the thisisgo.ie website and go into that leaflet about vulvovaginal health. It goes through a complete list of all the different types of vaginal moisturizers and different lubricants that are used when it's not reasonable for you to go on, in your case, to go on local treatment. But if you're not on a clinical trial, even if you had ER positive breast cancer, for the vast majority of women, vaginal estrogen is safe and effective. But I cannot emphasize enough, my colleague Yvonne O'Mara, kind of in conjunction with international experts, created that leaflet, and it is brilliant. And I think every woman who's dealing with local symptoms should have that on her phone, so that she can refer to it when needed, because it really is comprehensive and full of information.
Excellent. Lisa, my breast cancer was HER positive, estrogen and progesterone negative. How does this affect with taking HRT? Nobody really knows the kind of accurate answer to that question. Our practice would be usually to kind of be cautious in prescribing HRT for someone who has a history of breast cancer, and to probably start first line with, non-pharmacological self-management strategies, and non-hormonal, not prescribable, non-HRT if needed for vasomotor symptoms, and only using HRT if those symptoms were weren't managed effectively by those. But it is a very specialized area, and it's hard to give you a kind of a hard or fast answer to that. But generally, we would try and start non-hormonal individualized decisions beyond that, if not effective. So Pascal, and again, after 3 years of menopause, I'm 39, I'm still not able to work. What can I do to improve the quality of life, especially in terms of brain fog?
So the brain fog is really difficult to manage. And in terms of knowing what treatments are helpful, we're not particularly far down the line on that. The mymenoplan.org website has a really good section on brain fog and cognitive issues. Often it can be a case of, trying not to take too much on, avoiding multitasking, so you're doing one thing at a time, and using lists and that kind of thing, so that you're not relying on remembering things, which I hope that doesn't sound patronizing or anything like that, but just trying to make sure you're doing one thing at a time, rather than trying to prioritize multiple things all at once. And to go to that mymenoplan.org website, and it goes through all the different information that we have about brain fog and cognitive issues.
Louise, for vaginal dryness, should we be starting with creams, or can we go straight to vaginal estrogen?
I think vaginal estrogen is the most effective treatment, so I would start there. It depends, I suppose, on your own preferences as well. Like some people, even though I'm saying it's safe to take vaginal estrogen if you have hormone-sensitive cancer, some people can still be very anxious about that. And if that's the case for you, then it's reasonable to start with a moisturizer if you prefer. But vaginal estrogen is the most effective, and it is safe in the vast majority of cases. So, that's what I would start with if it were me.
Very good. Pascaline just saying thank you. So I suppose if we haven't any more questions, maybe we'll let you go and wish you well in your future career. Fionán, thank you very much. Maybe there's a last question coming in. Oh yeah, thanks for your answer from Lisa. Can you pull up that document from Yvonne again?
If you go on thisisgo.ie and create an account, it's called Improving Your Vulvovaginal Health. That's Improving Your Vulvovaginal Health. It is excellent, really worth checking out.
Very good. And you can check in with your cancer support centres anyway, or call the support line. We'll be able to help you out with that again as well. Okay, is that
Thanks very much.
Thank you very much.
Slán from Limerick.
Take care. Bye.
Bye-bye.